Hello and welcome to On Call with the Prairie Doc After Hours. Excuse me. We had many great questions submitted. Thank you for that. What we could answer during the day, during the show, we couldn't quite get to all of them, so we'll do that right now. A woman from Rapid City asked, what should the next step be after you hit out-of-pocket maximum? Jim, do you have any comment about that?
What do you mean, the next?
What does she do now? She's run out of, the insurance says you've reached your maximum.
That shouldn't be legal, but
I don't.
under Obamacare, that shouldn't be legal.
Yeah, I don't think that can't be.
Okay.
Because,
There is no.
under Obamacare, the insurance companies are not allowed to charge annual and lifetime limits on coverage anymore.
No, that's gone.
Okay, great. Please comment on how duplication of services.
But, that was, that's like with Obamacare. I mean, there were things in Obamacare that were really focused and very good, in terms of like that. And I think where Obamacare got the bad rap and where it kind of went wrong was to try to do globally so many things. And we were talking before, I have people in Western South Dakota who bought an insurance policy and there's nobody that takes that insurance. So they're insured, yeah, they got insurance, but
there's no doctor.
There's no doctor. They got to go to Denver if they want to go see the doctor. Okay. Yeah. So there's problems. There's problems, and it's got to be tweaked, and it's got to be, it's just like you're talking about the competitiveness and the patents and everything. That should be fixed. That should be something that people look at, so we get some real competition on some of these drugs, and we don't have all this horsing around where for 80 years you spend a nickel for a colchicine tablet, and all of a sudden it's $5 because somebody got some exclusivity on it or something.
Yeah, it's not
That's
$5.
crazy.
It's $600.
Well, I know, but I'm just colchicine.
Yeah,
it's an example where it went from a nickel to $5 a tablet.
A tablet.
I'd love to see the day where we get past the stale debate over, on one hand, repealing Obamacare, throwing everything out, including all the good it does, or digging in and saying it's fine, leave it alone. What we need is Republicans and Democrats to come together and figure out what is working well and what can be done for the parts that are not working well, like the lack of insurance competition in many markets.
Right.
And I think there are bipartisan solutions out there, but what we need is a change in the politics of this country where we begin to talk about shared solutions rather than partisan gridlock.
But I think that, this is just my take, and maybe I'm, you're there and you're, doing this stuff, but it seems to me that taking that kind of bottom-up look at this in terms of the problems, these very specific things, and getting a bipartisan support on things that everybody can agree on. Okay, we need competition in the drug thing. Okay, now how are we going to do that? There are going to be certain ways that you could do it, certain ways that be acceptable to some, not to others, right. Whatever. But we should be able to solve that problem. Yeah. Much the same as we were taking this caps on the total cost. Get that, all those things. You could come up with a long list of little fixes that would move us forward, don't you think?
One of them should be take the biggest lobby in Washington, which is the pharmaceutical industry. It's spending, what, 40
You mean they're bigger than the ACP?
They are bigger than the ACP.
They're bigger, much bigger. Much bigger.
There you go. Good one. The best one of the night. Please comment on duplication of service. Well, that's it. We talked about that. Will there ever be a cap on charges Big Pharma can charge for drugs in our country? A cap? Will there ever be a cap? Bob?
He would know.
I think it's unlikely that you're going to have a hard cap, rigid price controls. And I think there's good reasons not to have rigid price controls. What I think you can do, though, is negotiate better prices for drugs, just like the VA does. VA has its problems. We all know that. But they do negotiate the best price for drugs. So I view price negotiation as being different than price setting. And then again, there are a lot of other things we can do, like the exclusivity of their patents, the abuse of that, bring more competition into the system without imposing rigid price controls.
And I agree with that by and large. But the problem, like with the VA, is that they just arbitrarily decide that they're not going to have that drug because it's too expensive. And so I go to them as a rheumatologist and say, Humira is not going to work and Enbrel's not going to work, and I want to give them Orencia. They say, we don't have Orencia. And I said, well, how do we get Orencia? We can't get Orencia. I said, well, they said, use Humira. Well, Humira, it doesn't work. And Enbrel, you know, and so you run into that where it's just rigid. It's not there, they don't have it, and they're not about to get it.
Yeah.
And so that's a problem.
Yeah.
You know, and you don't run into that on the private side as much. You know, you may have to pay more to get the Orencia, but you at least have some access to it.
Yeah. A comment, I just filled a 30-day prescription for Restasis eye drops. My copay was $30. Without insurance, the cost would be $635.99. So it's this cost of healthcare is just and the drugs just drive me crazy. I'd ask you both to kind of give me your bottom line, your take-home message that you want to make sure that everybody hears tonight. Finally, Bob, I didn't get a chance to do this on the show. We just ran out of time. This is too important of a topic and a hard topic. Bob, what would your take-home message?
You know I'm a big baseball fan, and today is opening day for baseball, but everybody's optimistic. And I say that because I am an optimist. Despite all the gridlock and ideological battles and arguing and all that, I've seen Republicans and Democrats start coming together on issues like funding treatment of opioid epidemic. I've seen us enact bipartisan legislation to reduce barriers to chronic care. And I see bipartisan willingness to talk about solutions to the high drug pricing issue. So I'm actually somewhat hopeful, because it is opening day, that we can move beyond stale gridlock to bipartisan solutions to many of these problems.
I know you used to sell beer at the baseball field. Do you still do that?
I don't sell it, but I drink it at the games.
Okay. All right. Jim, do you have a take-home message that you want?
So like Bob, I'm an eternal optimist as well, okay? And I'm also a big baseball fan, but unfortunately my Cardinals lost at the Mets today, but otherwise.
I'm a Met fan.
Oh, God.
You and I can't agree even on that.
So you know, the thing is that I do think that if, you know, that if we step back from trying to do global policy changes that have all unintended consequences, and we go from that bottom up and look for those problems that we can get people to work together on and start to solve it from that direction. I'm optimistic as well. And the other thing is, you know, I am excited about some of the things in the insurance world that we're doing at Dakota Care and Avera in terms of care coordination and working, you know, with the ACO people and the case management people and analyzing our patient populations in terms of what the illnesses are and what we need to be looking for. I mean, it's a huge opportunity, and if you do that right, that has got to be a more cost-effective way of delivering care. So I'm excited about that.
One step at a time.
Yeah.
I look at 8% of the GDP spent on administration of healthcare, and in our country, and 3% in these other 10. And I look at that as a major issue too. But the complexity of how it's figured out who gets paid what, and I think it's just too complex. I think if we could just simplify payment systems, there would be a huge benefit. I don't just know how to do that. That's all.
Well,
I appreciate you both. Thank you so much. So good to see you. So good to see you again, Bob.
Yeah, great to see you, and hopefully I'll see you. I think I'm going to be out in South Dakota for the fall meeting, so.
I'm planning on speaking.
Good.
So I hope to be there too.
All right, great.
Great.
I see you,
Thank
Bob.
you, Jim.
I don't even know where
Nice
to wave
seeing you,
at
Jim.
you there.
And
there,
thank you
whatever.
for joining us on Facebook page. We appreciate all of your questions and the opportunity to answer them. So until next time, from all of us at On Call with the Prairie Doc, stay healthy out there, people.